will take up the first topic, that is anemia during pregnancy.
Now in this particular session, this session is meant for the privatization of healthcare in India. That how the private is. So before we go on to the privatization of the healthcare, we have to understand what is the healthcare delivery system in India. I think you must have gone through, now it's fairly long time, that almost 1 year, 1 साल हो गया आप लोगों को. You must have read about that, what is Bhor committee and what are other committees. You must have read the recommendations of other committees, and you must be very well aware that what is the existing health infrastructure in the country. So just to tell you brief, if we see at the lowest level, if we speak of health infrastructure, if we see the lowest level, we have got at the village level, we have got one health worker, one community health worker, ASHA or volunteer or village health guide, and one trained DAI we have got. And this is normally the norm is that one person each for 1,000 population. And their job is to just make home-to-home visit and try to detect the disease, give the try the home remedies, and the job of the TBA is to manage the normal deliveries at the home and to identify the difficult and the complicated deliveries and refer them to the appropriate referral center. Then if we move little further, then we got a sub-center which is at the population of 5,000. And this is in 5,000 in the normal areas. But if we see the tribal areas or the hilly areas or difficult areas, hilly areas or your desert area or backward areas, there the norm is that one health worker is for 3,000 population. At the sub-center you will find two health personals. One is a male worker and second is female worker. And there have been, earlier there was a delineation of the duties of the male worker and female worker. Now since there has been horizontal integration of all the vertical programs, both the workers are responsible for that holistic health care in that population of 5,000. So this is the services which are available at the level of 5,000 population. Now if we go little further, then we have got a primary health center, and this is in this primary health center, this serves the population of 30,000 in the plain areas, hilly, desert and the difficult terrain areas and tribal areas. This population served by them is 20,000. And this primary health center is basically responsible for providing the primary health care. And if you know the definition of primary health care is basically essential health care which should be made available to each and every individual at a cost and at a cost which everybody can afford. And there are certain principles, and I think you must be knowing that there are 8 elements of primary health care. That first is that nutrition, then sanitation, then maternal and child health, immunization. Then we have got treatment of locally endemic disease, treatment of common first aid and emergency disease. Then we have got availability of essential drugs. So these are the 8 elements of the primary health care. And the basic principles of primary health care are equitable distribution, then equitable distribution, appropriate technology, and community participation. I think we have already talked about some of these components earlier also. And then as we move further, at the block level, we have got a community health center. The community health center block is a normal average population of the block is 1 lakh. Normally it is from 80,000 to 1 lakh 20,000, but on an average we take one block at on the population of 1 lakh. And this community health center is also known as first referral unit, because this is why this is known as first referral unit, because this is the institution where some specialist services are available. Here a surgeon is available, a physician is available, pediatrician is available, and part-time anesthetist is there, so, and a gynecologist is also there. So this at block level, this, and we have got some beds, 30 beds also are available at community health center. And the nomenclature is little bit different in different states. Somewhere they call it community health center, somewhere they call it upgraded primary health centers. But basically these are all, if we see, they are the first referral units. So these units are having 30 beds, some specialists, and they provide the basic health services to the population of that particular block. Now if you see, if the patient is, say at 5,000 population, if a health worker is able to manage the patient with whatever the training that person has got, if available, if he can manage, then it's all right. Otherwise that person refer that patient to the primary health center, where it is managed by a qualified doctor. If not, if he is not able to manage, the case is more complicated, the complicated cases are referred to the CSC, and in CSC the specialists are available and they are given the indoor facilities. As I told you, 30 beds are there, so indoor facilities can also be provided to them. And further we go, we have got district hospitals, and district hospital, as you know, that all the special services are available, and district is the basic place where all the national health programs, when we say that DOTS program, leprosy program, the programs for TB control program, DOTS program I have told, and then other like malaria, other communicable disease, integrated vector control program. These are all basically placed at the district level. And we are trying to, when we are, if you are undergoing this course, we are trying to make you as the district health manager, so that at the district level, if you have to manage the health services, how you should manage. And above that, there is a state level services and then central level. I will not go into that thing. Now you see, like I was talking to you about that the Bhor committee has given certain recommendations, Budaliar committee has given certain recommendations, then Kartar Singh committee has given certain recommendations. But if you see over a period of time now, it is almost more than 60 years after independence, the services are not to the desirable level. Whatever the recommendation has been made by Bhor committee in 1946, they are still not being implemented. If you see our bed population ratio is very low, and so what has been felt that there need to be a privatization of the health services. because the public sector or the government sector has been not able to fulfill the demands of the whole population. The reason may be many. It's not that the funds are not available, the trained manpower is not available. There are various, I think in last 3-4 teleconferencing, people have discussed about various social factors, socio-economic factors responsible for not getting the healthcare delivery by the people from the government sector. And that's why you must have seen that more and more private sector hospitals are coming up. You see advertisement in that Max Group is coming, the Apollo Group is coming, then Fortis Group is coming, other groups, some in South, Vocart Group, and so many private players are coming into the action. But basically, if you see these institutions, the private sector, they are basically catering to the need of the higher bracket of the people, that higher people from the higher economic groups are those who are insured. Because a normal person living at the rural areas or in with a nominal income, I will not say with no income, people definitely are not able to afford, but even with the nominal income, they will not able to afford the services of the private sector. So they have to depend upon the government sector. So now we have got two options: either to improve our public health care system, or to allow to give it for privatization, outsource the various services, or we make a marriage of both. We do that, a mix of both private and public. Maybe government and the private institutions can join hands and work out a strategy whereby the goal of health for all is being achieved. So that was the basic need. You must have seen that if you go to primary health center or a hospital, there are various problems people are facing. Sometimes doctors are not there, proper manpower is not there, and then in some places proper funds are not there. Then if doctors are available, then the other paramedicals, trained manpower is not available to provide the required health services, which the primary health center or sub-center or then maybe district hospital or the tertiary hospital or the medical college hospitals are required to provide. And then if one point is this, and second is man is not there, money is not there, some materials are not there, some equipment. Now you see that as we progress, if you see, go back 20-30 years back, the treatment of the patient was a basically very simple mechanism, that patient goes to doctor listen to him on based on the clinical symptoms. Doctor makes a provisional diagnosis and try to give the symptomatic treatment, and the patient goes home. And if certain tests are required, then the patient is advised certain tests, and based on those investigations, doctors modify the treatment and the patient gets cured. But now if you see with the increasing technology, now so many equipments, we see 30 years back there were no ultrasound, no MRI, no CTs, and all these things were not there. No this cardio thoracic surgeries, no neurological surgical interventions were there. But with the passage of time, with the new discoveries has been made, new equipment have come, new technologies have come, and these are definitely a costlier affair. Now if you see the method of treatment of the patient. This is basically based on the more of the diagnostic rather than the clinical judgment of the clinicians. So that's why the cost has gone up. Second, other thing is that the people behavior, that people mindset has also changed. People believe, or over the period of time, they have experienced that services are not available at in public hospitals, not of good quality. They have to wait long. They have to spend long hours. They have to lose their wages for getting treatment from the from the government hospitals. So they naturally, their attitude becomes that let us go to the private hospitals. And it has been observed by many studies are there that in that process they lose their wages also. Sometimes they have to, even middle class people, they have to shed away a lot of money. Even they have to put some of their capital things, some land, they have to sell it and use that also. So that was the basic reason that why the privatization of the services was required. To understand this in depth, we will require to go into the details of that, how this private sector has grown over a period of time, how the things have changed, how this private sector can be give more meaningful services, so that our goal of health for all is achieved. Now, this is a brief in I have given you an idea that what are the government services and why there is a need of private services, and why there is a more focus on diagnostic services. And there is one more reason that if you know that there is a Consumer Protection Act has also come into that, which is also applicable to the now the medical or health sector. Earlier it was not applicable, it was only for the consumers goods, but now it is also applicable to the, so the doctors or the healthcare providers have become more conscious about to save themselves. That's why they are giving, they are asking for more and more tests and more diagnostic procedures are being carried out. So I think I have given you a brief overview of that, how these services are available in India and what is the basic need of having privatization. Now we have got with us Indranil, and he will be telling you about this growth of private sector in India.
Today we'll look at the private health sector in India and its consequences on people's health. We'll be looking at the structure of private health sector, how it has grown over time, what are the reasons for the growth, and then what are the consequences of this growth on access to healthcare, cost of healthcare, universalization of healthcare, and several such aspects. Briefly at the end we'll talk about the future, what should be done about the private health sector, whether regulation is something which can be thought of, and what are the status of present legislations on that. To start with, I'll briefly show you a chart where we can find out what is the magnitude of private healthcare in India. And if we see that, if we see private healthcare as percentage of gross domestic product, we find that India is placed much higher than many of the developed countries, even like Canada, United Kingdom, Spain, so on and so forth. Whereas developing countries are concerned, this is India's private health sector is much bigger. In contrast to that, the government health sector is among the smallest in the world. India spends only 0.9% of GDP on health and the public expenditure, and it's among the lowest in the world. Now if we look at the structure of health system in India and who spends what, we find that of the total almost 70% or 68.8% is spent from people from their own pocket. So when we say that 2.7% of GDP is private, we have to know that a large part of it is people spending from their own pocket, which is very regressive nature of financing. Now let us look at the structure of health, private health sector. We know that in India there is no systematic data about private health sector. The registrations are not proper, but the National Sample Survey has done some estimates about the private health providers, and it says that there are 13 lakh enterprises providing health services in the country, excluding obviously public facilities, and majority of these enterprises are own account enterprises run by family or household without employing any formal worker for a sustained period of time. They constitute 80%, whereas other health establishments which are proper facilities, they are only 20% of the total, and out of these there are 42,000 hospitals and nursing homes. So the contrary to the impression that private sector is dominated by hospitals, nursing homes, good facilities, the reality is something different, and in rural India 93% of the facilities are own account enterprises, and a fourth of these enterprises are ISM practitioners or health facilities. So and if we see a trend analysis of 4 periods, pre 1980, 84, 1994, 2004, we see that sole enterprises have remained same, whereas partnerships have evolved over time. In number, corporate hospitals still are small segment, but we'll look into detail of it. Significantly, trust hospitals have given way to different forms of partnerships. Whatever limited information we have on private hospitals and beds, we see there is a significant increase over time. Health Information of India shows that from 1973 to 2002, private hospitals have increased 10-12 times, and similarly beds have also increased significantly. We have to note here that since 1990s, this increase has been even more significant. Now, National Commission on Macroeconomics and Health in 2004 conducted a facility survey to find out what is the share of public health facilities and private facilities, and the figure here shows that the line at the bottom, which shows the public facilities, are very small in number. There is hardly any growth in the number of public facilities, whereas the line at the bottom shows a huge increase, which is a private facility. So private facilities over time, especially since mid 80s, have increased significantly, whereas public facilities have almost stagnated. However, when we said that the own account enterprises dominate, corporate hospitals are very few in number, we also have to know that in metropolis, big cities, the corporate hospitals take a huge share of total hospital beds. Here we have divided hospitals in terms of bed strengths and in 5 categories. The columns with light color show that hospitals with different bed strength and their share in total number of hospitals. We see that as bed strength increases, numbers decrease, but at the same time, with increasing beds, the total share of bed increases. The point here is, like, hospitals with more than 100 beds, which are at the right end of our stratification, we see they are only 4% of the total hospitals, but they constitute almost half of the total beds. So though they are limited in number, big hospitals dominate in terms of supply, at least in big cities. Now, as a consequence of this, share of private hospitalized episodes and short duration ailments have increased. Short duration ailments were from the very beginning were dominated by private sector. By mid 80s, they were constituting almost 3/4 of the total short duration ailment, and but in the hospitalization, share of private facilities was less. around 40%, but it has increased over time. As we move down, we see that share of private facilities in hospitalization has increased. What are the reasons of this growth of private sector? We see that the most important reason is that low level of investment, public investment in health has stunted the growth of public health sector. But as society moves, as economy grows, the demand for health services increases. So to cater to that demand, private facilities have tried to fill in the vacuum. Now, here the pertinent point is why did then public facilities didn't grow? Then if we look at the emergence of middle or upper middle class in urban areas initially, and then in the rural areas after Green Revolution, we see that there is an increase in the purchasing power of a small section of the population who gradually drifted away from public facilities and started accessing private facilities, private hospitals. So there was a demand created, but then at the same time private health sector has grown due to huge subsidies or supplements provided by the government in terms of cheap land, different kinds of subsidies, or through different initiatives of public private partnership, which we will deal in the later section. Now, as I was explaining that lack of public investment is one of the major factor, the graph shows how it has moved. Our public investment has remained low since independence. So it grew in the first 3 decades, but the level was very less. But then since economic reforms were initiated, that growth was also halted and it went down during 90s, slightly recovered in the later period, but overall the public investment has remained low in India. One of the significant consequences of this growth of private facility is the increase in out of pocket expenditure. If we see that average per capita monthly out of pocket expenditure incurred in for health has grown significantly. It was 17 rupees in 93-94, which went to 42 rupees in 2004-5. And this constitutes 5 to 6% of households' total expenditure. So, out of pocket expenditure on health constitutes 6% of total household expenditure. As much as 2/3 of the households now report out of pocket expenditure due to health reasons. And many, almost a sixth of the total households spend 10% or more on their health. As we know that these have severe consequences on universality, comprehensiveness of care, equity and access. These are very important yardsticks for us to judge any kind of health service. Increase in hospital costs. So average cost per hospitalization from government and private facilities vary widely. Surprisingly, over the 80s and later, even in the 90s, government costs have increased, but they are much less compared to what people spent in private facilities. However, a large part of the cost incurred in government facilities are due to drugs which are not available at the hospitals or the health facilities, and this is one of the significant drawback that need to be addressed over time. Unfortunate aspect of growth of public facility is the increasing level of untreated morbidity. If we see in rural and urban areas, mid-80s, mid-90s and 2004, there is an increasing reporting of financial problem as being a deterrent for healthcare, and especially so in rural areas. Of the total untreated morbidity in rural areas, almost 28% people reported that it is because of financial reason that they couldn't access. Obviously, no medical facility is another unfortunate cause of not accessing. So basically, lack of public facility and due to high level of cost at the private facilities have led people not to access health institutions or access any kind of health services. Denial of access to poor and vulnerable is one of the other aspect which needs to be looked into very seriously. both reporting and treatment of illness is more among the rich, the urban people, and people living in higher social strata. So poor in urban areas, poor in rural areas are not accessing health facilities at all, whereas the rich people are accessing it. Urban households in the poorest MPC, monthly per capita consumption expenditure class, are 4 times less likely to be treated against ailments than those at the highest class. So a poor person falling ill is 1/4 likely to go to go and seek health care than his counterpart at the upper strata. For rural India, it's more significant. Reporting of illness is also very less among the poor, the marginalized sections, scheduled tribes. As a result of this lopsided growth of private sector, the profit of private hospitals have grown. We don't have figure for all the hospitals, but the corporate hospitals have some figures, and we see that from 2001 to 2007 there is an enormous increase in the income of these corporate hospitals in terms of rupees crores. The poor depend on public facilities more. They due to financial reasons, due to other reasons, poor go to public facilities more than the richer counterparts. Lowest income class, 40% people access public facilities, whereas at the highest income class it is only 23%. So a huge number of poor still depend on public facilities. Had it been universal, had it been greater coverage, definitely this access would have increased. Private sector costs, as I mentioned earlier, are much higher than public sector costs. Now, suppose for a normal delivery at the private facility costs 18 times more than that of at a public facility. Caesarean section 24 times more at a private facility than a public facility. Major surgeries 20% more, like that. So public facilities are much cheaper, but still people have to depend for their illness on private facilities because of lack of services. Now, another important aspect of health service or one of the trends that we need to observe very carefully is a phenomenon of public-private partnership, which have grown during the economic periods of economic reform since 1990s. Now, it has to do with the changing perspective of government and international agencies. Now, the role of the state is being limited to policy making, whereas the service provision is being seen more as the domain of private sector. Whether this has good consequences or how it has increased access and efficiency has to be looked into. There are several forms of public-private partnerships. Mostly it is in the form of contracting in services, like private providers are roped into public facilities to conduct tests, to do some other things. Some times services are contracted out. Some PHCs nowadays are being run by private providers, NGOs, so on and so forth. And then there are several ancillary services which are provided at hospital levels through private facilities. Then there are issues of social franchising, joint ventures with public and private. There are several universities being created for public health on this joint venture model. So state's role has been limited to providing subsidies, providing expertise, providing technical knowledge and supplies, while non-state actors' role is mobilizing communities, detection and follow-up. The common notion is that private facility bring in additional capital and capacity in low income countries. Since the argument is, since the state cannot spend much, additional capital will be generated by the private sector. But private sector require huge amount of subsidies. Subsidies are in different forms. Direct cash subsidies, subsidized medical education, free land, free infrastructure, different tax breaks, but at the same time providing human resources, medical education. These are different forms of subsidies through which the private sector sustain. Now, private sector also competes to provide care in the urban areas and not in the underserved areas. That because rural areas which are generally underserved are not taken care by the private facilities. It draws away human resources and technical resources from public sector. Several government doctors, financial reasons move out of the public facility. But then what is the future? How do we take a control over the private sector or help it move in the right direction? One of the major argument here is that regulation can be the way forward. There are several regulations that are in place, but some state level regulations, but mostly outdated regulations, ineffective in implementation, absence of rule, ineffective content of rules. There are several reasons. As a result, there is a new legislation that has come, which is now presently in the form of an act. It is called Clinical Establishment Registration and Regulation Act. The act aims to register all clinical establishments, including pathological labs. It aims to set up national and district councils, and this can be taken as a positive welcome step, but obviously there are certain limitations of it. To sum up, we see that private sector has grown over time in the last few years. It has grown through public subsidies, it has grown through different forms of partnerships, but it needs to be regulated and needs to be supplemented. Thank you so much.
Thank you, Indranil, for giving very comprehensive and lucid presentation about that privatization of healthcare services. And I think you have made a very important point that public-private partnership, I think that is the answer to deal with the providing of healthcare services to all in near future. So I think he has tried to make a point that since the government services have been not able to provide the necessary things, therefore the privatization is required, and he has tried to show you that how the private sector the costs are involved and why it has grown over a period of time. Thank you, Indranil, for being with us and giving very useful inputs to our students.